Welcome to the Healthy Living Series, a series of talks brought to you by the University of Alaska's Summer Sessions and Lifelong Learning in partnership with Foundation Health Partners. My name is Joan Braddock, and I will be your host for this summer series. The Healthy Living Series, in its 8th season, has been a lecture series held in person in past summers. The COVID-19 pandemic and social distancing guidelines required that we rethink the format for the series this summer. We are delighted that KUAC has agreed to support the new format for the series as a weekly TV broadcast. We are also grateful to our speakers who were willing to be incredibly flexible in adjusting to this new format, and we appreciate the time they are donating to help us all live a healthier life. Before I introduce tonight's speaker, I want to let you know that you will be able to view the talks online after they have been aired by going to the UAF Summer Sessions' website at uaf.edu/summer/events. I am now delighted to introduce our speaker for this evening, Dr. Peter Dillon. Dr. Dillon joined the Tanana Valley Clinic First Care team in October 2013, and he now serves as the Director for TVC First Care and Addiction Medicine. Dr. Dillon came to TVC from the U.S. Army, serving at Fort Wainwright for the preceding 3 years. Dr. Dillon continues to serve as a Lieutenant Colonel in the Army Reserves and has deployed multiple times, supporting special operations and conventional combat and contingency missions around the world. Dr. Dillon began his education at the Ohio State University, where he graduated with a Bachelor of Science in Nutrition. From there, he attended the Georgetown University School of Medicine, where he completed a Doctorate of Medicine in 2007. After concluding his doctorate studies, he went on to complete his residency in family medicine. Dr. Dillon specializes in family medicine, but also has interest in addiction medicine, wilderness medicine, pre-hospital medicine, and combat and tactical medicine. On a more personal note, Dr. Dillon enjoys hiking, fishing, and exploring Alaska with his family. Tonight, Dr. Dillon will be talking about the very important issue of another pandemic, substance abuse, in his talk entitled Use Abuse Disorder, describing substance use disorder. Because of the importance of this topic, we will be airing this talk in 2 parts, with part 2 being aired next week at the same time and station. If you miss one part of the talk, remember that you can also view the talks online from the Summer Sessions website. And now, Dr. Dillon.
Hello, my name is Dr. Peter Dillon. I'm a family physician here at Tanana Valley Clinic, and I'm excited to participate in the summer sessions. We're doing things a little differently this year. Obviously, I'm talking to an empty room. We're in a conference room. I'm talking over PowerPoint with the SARS-CoV-2 coronavirus. These are still very important topics. While we're going to talk about a very important topic to me personally, it has impacted a number of our community members and certainly is a topic that we didn't want to wait. I'm very passionate about this. I hope that comes through in my talk I'm going to give with you this evening. Or what I like to do is usually talk to the audience, not talk to PowerPoint. Normally, I don't use PowerPoint. Normally, I just talk to folks and answer their questions. I will hopefully have addressed a lot of those questions as what people commonly ask me in our talk this evening. But to acknowledge that this is unusual, it is different, it's a little bit outside my comfort zone, but hopefully the information that I get to share with you all will be helpful, and we'll go ahead and talk about the use, abuse, and disorders of substance use and drug use as they impact our community, specifically in Fairbanks, Alaska as a whole. But what we're talking about is the previous other pandemic of the opiate crisis is mainly what we're going to focus on. But I'll define what substance use disorder looks like, some of the impact that that has had to our community, as I mentioned. We're going to define what addiction does and what that means. How do we treat it? what are the medications that we use, and then what does an outpatient or inpatient follow-up and long-term management look like, and how we can help those folks in our community. So, the other pandemic. I just spent a little bit of time talking about SARS-CoV-2, and one of my jobs when I'm not doing addiction medicine is I do work at Tanana Valley Clinic's First Care, so we have a front row seat for that. But what got me into addiction medicine in the first place was actually working at First Care and seeing just how many folks had such profound health impact from the opiate crisis. And so myself, as well as the other physicians in the addiction medicine clinic, most of us work in those frontline type of practices, emergency medicine, urgent care, things like that. But as we kind of walk through, there is a lot of lay press that has been dedicated to the opiate crisis, and certainly for good reason. As we go through some of these statistics here, our previous Governor Walker issued this declaration of the healthcare emergency for our state. President Trump has issued a similar national health emergency, and as we look through some of these statistics, there's no positive statistic as it comes to the opiate crisis. Certainly we can see hundreds of percents or multiple-fold increases in heroin-associated deaths, and that comes across all categories of death, whether it's intentional overdose, accidental overdose, whether it's a healthcare-related complication from substance use or injection drug use. We don't do well relative to the national standards or averages either. And basically, the biggest thing that I point to whenever somebody talks about how devastating has this been as a national concern is that for the last 50 years, without interruption, the life expectancy in the United States has steadily climbed, despite numerous other healthcare measurements showing that we are less healthy. Obesity is up, rates of diabetes, those are up, rates of heart disease, things that kill people have steadily increased, yet our life expectancy as the United States has steadily climbed. Until we get to 2016 and 2017, when we see the life expectancy in the United States dip for the first time. And that's not because we got worse at taking care of people with heart attacks, and that's not because we magically had more diabetes. That's because 20 and 30-year-olds were dying of opiate use disorder, specifically dying of heroin overdoses. And so this splashed across the national news in many, many ways, but ultimately it is really hard to argue with this problem was so severe that it reversed a trend of decades of life expectancy increase. So for me, that is a very telling sign of just how pervasive and how devastating this problem has become in the United States. So again, first time in 50 years that people lived less long or died sooner, however you want to look at that, all because of mainly due to the opiate crisis. So how do we define it? Substance use disorder. Basically, this is what happens when use becomes truly problematic for an individual. And so people can use alcohol, people can use drugs and still maintain normal function. They can show up to work, they can be around their family, they can do a number of different things. It doesn't directly impact their health immediately. What causes it to become problematic is generally it starts to impact health, it starts to impact relationships, starts to impact people's ability to function at work or whatever, school, things like that. Once you achieve that level of impact, then that is the definition of a disorder. So that's what people would generally define as addiction, or the behaviors that people exhibit to continue to use these substances start to become problematic. And so whether that's socially unacceptable behaviors, whether that's illegal behaviors, but once people start to function outside of what is normal and acceptable for society, that is when these behaviors are viewed as problematic. So the substance use becomes a disorder when you meet that threshold. Now, lots of different factors. Nobody knows for sure. There's the nature and nurture argument. Is this a genetic? Is it a social predisposition, that if you have parents who use drugs, are you going to use drugs? Is your peer group to blame? Again, a number of these things all factor in. There's not one thing you can point to that says, this is the risk factor that's going to define, does this person have some substance use that's not problematic? Do they never touch drugs at all in their lives? Are they somebody who can be a functional, which is a term that used to be thrown out, a functional alcoholic, a functional drug user? Again, we don't define it that way, but certainly we do realize that all of these things do impact. Not one of them is the only deciding factor. Behavioral health disease is a big component of this, and we touch on that. Anxiety, depression, numerous behavioral health diagnoses. Environmental stressors can play a role as well. And what that means, especially when it comes to the behavioral health disease component, is people misuse substances when they don't have great access to good behavioral health treatment. So if you don't like the way you feel about yourself, a way to not feel that way is to use substances to the point of intoxication. So an escape is another term that gets thrown out there to describe that behavior pattern. So again, one of the things that we identify is that people oftentimes will self-medicate. So again, unless they have access to good behavioral health care with evidence-based treatments to medications to treat their behavioral health disease, many people will reach for substances that alter the way they feel about themselves. So whether that's methamphetamine or other stimulants, opiates such as pain pills or heroin, alcohol, again, these are all things that alter people's ability to feel the way they do. And again, if you don't like the way you feel about yourself, then that is a way to treat that underlying disease. So one of the things I did point out is children are particularly vulnerable, and we'll talk a little bit about what that looks like as folks grow up seeing substance use or seeing the violence that comes as a result of substance use. These are things that predispose them when they're older to develop these same types of substance use patterns. So again, is that nature? Is that nurture? Is it genetic? Is it the fact that they grew up in that house, or they didn't grow up with parents and so they're a product of the foster system or something along those lines? Again, there's lots of risk factors. Not one of those points to this is what's going to define someone, and it doesn't mean that a person is going to end up with a substance use disorder. But many people who have substance use disorders have a number of those things that we've just discussed. So what does it do to Alaska? And these are mainly financial measures, but certainly these are devastating diseases. They destroy families. They cost lives. People die. They have major health impact. But again, right now, when we looked at the most recent data, so 2018 is the most recent data, $3.5 billion with a B, that's the $1 billion, are attributed. And that's direct cost, meaning it costs this much to treat someone with substance use disorder, what we do in the addiction medicine clinic, but also the indirect costs when you don't show up to work because you were intoxicated, or because of the damage you caused to property when you crash a vehicle, or any of those things that are a little more difficult to calculate. But the projection right now is that $3.5 billion is the cost. And so majority of that's alcohol. Again, we'll talk to some of the reasons why in a little bit, but it's a legal substance, so it's a little bit easier to obtain. There is an industry built around alcohol, and so it is easier to get, therefore that likely accounts for the larger percentage. It's probably a little more devastating from a standpoint of the driving under the influence. Again, not limited to alcohol, but certainly there is a higher percentage of that as well. And then again, healthcare costs are a big part of this, and that's both direct when someone gets admitted to the hospital after they've had a crash from a driver under the influence, injection drug costs. So if someone develops an infection from injecting heroin into their arm, for example, those are direct costs. But another piece that also is a burden, and many folks will point to this, is the overlap in the criminal justice system, particularly as it pertains to Alaska. But majority of inmates in the Department of Corrections do have some component of substance use disorder as part of their overall social picture. So here's a pie chart that does go over that cost as it break it down. Again, I talked about traffic crashes and collisions, the criminal justice system as well. But that productivity loss down there in the corner is another one that's hard to capture and probably is actually a little bit low. And in my opinion, again, I didn't do the study, nor did I have a hand in it. But again, it is not an insignificant number, still measured in the billions. So when you look at that, that's thousands of millions. So we're talking about billions of dollars lost in productivity from our fellow Alaskans in our community. Now, the state does a great job, and most of this data that I'm quoting is actually something you can search online. There's an Alaskan opioid data set that you can look. We have a scorecard where we keep track of what we do, and you can look at everything from emergency department visits to overdose deaths, even down to the administration of rescue medications by our first responders. So there is a lot of data out there. It's being studied and refined. I'll be honest with you, the last few months, SARS-CoV-2 has taken a front seat, but it's still out there, and there are some publications that are looking at actually an increase in substance use because of the social isolation, as well as some of the things that go with that, depression, things, you're out of your normal routine. So if you're a busy person who normally would work 60 hours a week, and that's the thing that kept you from using alcohol heavily, but because of the COVID lockdown, you lost your job, and now your recourse is to use substances. So again, I believe as we see what the SARS-CoV-2 impact is to our society, a not small percentage of that will actually be an increase in substance use disorders. So again, a little early for me to say that definitively. There are some studies that point to that, and as we see the behavioral health impact of what this has done to our community, I believe substance use will probably be a substantial part of that. So this table just summarizes the 12 months preceding. Actually, I pulled this data 3 days ago. So the last 368 days of how did we do using treatments as well as substance use. So what is addiction? And I am a child of the 80s, and so this public service announcement of this is your brain that cracked the egg and this is your brain on drugs. So I went through the DARE program. I remember Nancy Reagan in a red dress shaking her finger at me saying, don't do drugs. And if you had asked me back in, I don't know, 10, 15 years ago even, what's a heroin addict look like? I would have told you, oh, that's easy. That's somebody, they live under a bridge and they push a shopping cart around, right? They're a homeless vagrant. They're marginalized. And that is true. We take care of patients in our community who fit that description. But the reality is people with substance use disorder are your neighbors. They change the tires on your truck every winter. They are checking out your groceries at Fred Meyer. These are people that are your neighbors. And we take care of everything from energy sector executives, very accomplished professionals, and then again, back to those marginalized folks in our society that was my preconceived idea as like I said, I grew up with the war on drugs and how we were going to stop this, then the gateway theory of substance use, that the minute you took a sip of beer, the week later you'd be doing cocaine, and shortly after that would be finding your way to score heroin. So again, not unfounded, and again, the idea that we're having a dialogue about substance use is important because a big chunk of this is actually the stigma associated with it. And that's not limited to substance use, it's also behavioral health disease. But if we pretend it doesn't happen, and we pretend that we can either fight our way out of it or buy our way out of it, we're gonna be fighting an uphill losing battle. So again, I always talk about my experience with what I understood from how do we identify substance use disorder and just how incorrect it was. Like I said, these are your neighbors, these are probably your family members for a lot of the people in our audience. And again, there's a couple of different studies that look at what is the percentage of people who've been impacted in some way by substance use disorder in Alaska specifically. And on the low end, and this is all community specific, but on the low end, about 10%. So 1 out of 10 people has directly been impacted by a substance use disorder. And there are some studies that put that number as high as 25%. So 1 in 4 people who's watching today or who's walking around our community has been directly impacted in some way by substance use disorder. So One of the things I always like to differentiate is addiction versus dependence. And this is really a clinical difference, but most people use the term addiction to describe both. But there is a subtle difference, and again, from a clinical standpoint, what I worry about is the dependence, okay? And that is the physiologic change. And the best way I demonstrate this when I'm talking to patients or to family members is what we define as tolerance. So I used to achieve a certain level of intoxication if we take the example of heroin, I would do 0.2 of a gram of heroin, and that was enough. But very quickly, I needed 0.2 of a gram just to feel normal, and if I ever wanted to achieve that at level of intoxication or get high, I would need 0.5 gram of heroin or a whole gram of heroin. So that's that tolerance. And then, more importantly, and physiologically, is the withdrawal symptoms. And that's a big part of what we do with our treatment program is if I decide to stop a substance, I no longer feel normal, or I feel ill, or I go through withdrawals. And that can be everything from shakes and chills, nausea, vomiting, diarrhea. A lot of the patients who I talk to who describe what does heroin withdrawal feel like, they claim it is the worst flu you can imagine. And then when we take care of alcohol use disorder and withdrawals from alcohol can actually be life-threatening. You can have a seizure and die from that. So again, these are not insignificant, and the physiologic changes that people undergo as they adapt at the metabolic and cellular level to these substances have real impact in what that looks like. So again, what I want to differentiate though is the addiction piece. And so that's the behavior. And so a key way for me to differentiate addiction as it pertains to substance use disorder is you can be addicted to things that aren't substances, right? We have people who have gambling addictions or pornography addictions, right? These are things that there is no substance, right? So physiologically, they're not undergoing a change at the cellular level like they do if they consume a liter of alcohol or a gram of heroin. The other way I demonstrate this is what it defines as socially acceptable. So in the United States, if you go out to dinner, for example, and you meet your server and they say, hey, would you like to have anything to drink today? Again, socially acceptable. You have a beer, glass of wine, happy hour, cocktail. That's socially acceptable to have a drink or two. Now, if you wake up in the morning and you drink 14 beers with your breakfast, that's not socially acceptable and generally somewhat frowned upon. And then furthermore, if you got behind the wheel of your car after consuming that much alcohol, now you've crossed into the realm of that's illegal behavior. And so again, the other piece there is, as we talk about, and I touched on this with the first set of slides there, the amount of impact that alcohol has on society. Again, it's a legal substance. And so there's an industry built that markets towards the use and consumption of alcohol. It's hard to watch a football game, or even when I drive home from Tanana Valley Clinic to my house, I'm gonna pass 9 or 10 places where I could stop and buy alcohol if I wanted. It's probably just as many places where I could stop and buy heroin, but I don't know about it and it's not advertised to me. So again, as we talk about opiate use disorder, specifically illicit substances like heroin, again, it's illegal. By definition, the minute you're using heroin, there's no legal amount of heroin to go and purchase or use. So again, as I talk about this, by definition, as soon as you're misusing opiates, illicit substances, you meet the definition of addiction. Again, maybe you don't have dependence yet, maybe you do. Again, it all depends on how long or how much you've been using. So what I wanted to kind of touch on here, and I alluded to this as I talked about what the preconceived notion of addiction was my idea, and the thought process, what was taught even as soon as 15 or 20 years ago, is actually probably wrong. And the idea that addiction is a disease and you need to treat it like a disease. And one of the things I tell every patient when they engage in treatment in our program is the idea that you get treated differently because you have this disease versus, let's say you have diabetes, or let's say you have hypertension. it's real. And pretending it's not a stigma that clouds the way healthcare providers interact with patients, or pretending it isn't going to impact your relationship with your family. Again, when you frame the process as a disease and you engage on the court system or with the law enforcement system or with family members, again, it's a big shift. And I will tell you, it's taken a long time personally for me to unlearn all those things I once knew. I have colleagues in the medical community who don't share my viewpoint, and that's okay. It's a shifting dynamic, and like I said, disease is going to involve relapse. It's going to involve those social isolation, as well as those individuals who are going to become marginalized. A lot of patients who suffer from substance use disorder don't want to get help because they've been treated very poorly by the healthcare system. They don't want to reach out to their family members because they may have destroyed that relationship that they had because of the activities or the way that their substance use has impacted that relationship. So what I'm trying to allude to is this is no longer about those individuals and it's their fault, right? That there's something wrong with them. They have failed morally, and that this decision was a choice that they have made, and if they just made better choices, then they wouldn't suffer from the disease. Okay, that's where we're shifting away from. And then the other piece is we're instead of focusing on sobriety necessarily, we're focusing on functional ability. So if you can get someone to be more functional, then that is a step in the right direction towards treatment. So as I mentioned, there's a lot of misconceptions. There's a tiny worded slide, and I appreciate that. But essentially, what we're talking about is a number of the individuals who were treated one way were probably given information that was not terrifically helpful and pointed towards continued use. And that was looking at things that abstinence-based programs are the only approach. Faith-based programs are the only approach. There was some data early on that if patients can control their own pain medicine at home, much like they've been able to do successfully in a hospital and supervised situation, that would be okay. And some of this we can, I purposely don't dive a ton into who's to blame for the opiate crisis in this talk. I'm welcome to talk to people if they want to come find me after this lecture. You see it. Is this Purdue Pharma and OxyContin? Is this marketing? Is it physicians? It's everybody. Everybody has some role of blame in this. But we gave a lot of pain pills to a lot of patients, and most patients whose opiate use involves heroin injection, and there's some pretty good science that supports this, but specific to Fairbanks, most people's first exposure to opiates was not, I went and bought heroin. Most people's first exposure to opiates was, I took pain pills, I crushed pain pills, I smoked pain pills. Very rarely do I meet somebody whose first opiate exposure was directly injecting heroin. So again, a lot of these different factors have played into why are we having this conversation today. And certainly at the end of the day, physicians with a prescription pad were part of the problem. Was it all their fault? Probably not. When I went through medical school, we were taught that you gave people pain medicine until they weren't in pain anymore. We now know that's probably not the right way to do that. We were concerned that there would potentially be risk from litigation if we didn't adequately address people's pain. And this idea that we could take pain as the fifth vital sign, meaning everybody got asked, what's your pain level? Some places we still do that. And it's important, and we want to manage pain, but that approach to pain management that happened in the late 1990s and early 2000s had an impact on how we are faced with an opiate crisis today. And to say how much was that to blame, I don't know. It's certainly a percentage. Again, I don't practice that way any longer. The docs at First Care, we address chronic pain very differently than we once did. And I think any physician who believes that they had no hand in this is probably incorrect. So again, some of this rests with the prescriber, ultimately, with the pharmacist. And again, at the end of the day, these are folks who probably, specific to Fairbanks, were managing their comorbid behavioral health disease with opiate pain medicines. And there is a substantial risk that's associated with that. Again, we go back to, if you don't like the way you feel when you're not taking opiates, and you like the way you feel when you take opiates, then you're going to take opiates. And again, we'll talk about the science a little bit. I try not to get too far into the pharmacology and bore people too much, but we'll talk a little bit about what that looks like. So I touched on this a little bit in the first couple of slides, but one of the other ways we describe how we address substance use disorder is under the model of what's called trauma-informed care. And this sort of speaks and formalizes the idea that substance use is a symptom of previously experienced trauma. And so different studies will look at as low as somewhere in the 50% of patients engaged in substance use disorder experience some form of trauma. I will tell you in the program we run here at TVC, it is 99%. Almost everybody has experienced some form of trauma, whether that's physical abuse, sexual abuse, emotional abuse, whether it's they witnessed violence when they were younger, whether they were a victim of that violence themselves. Again, trauma-informed care takes the approach of, instead of why is this person this way, why is this person using heroin, we take the approach of what happened to that person that led them to use heroin, right? This is a manifestation of what their experiences were. And generally, it is early childhood. And so there's a screening that we look at, adverse childhood experiences or adverse childhood events. And so generally, patients who experience multiple traumas early, before age 6, are much more likely to suffer from substance use disorder and comorbid behavioral health disease. And what we've had to do, and it's very, very hard to do this because oftentimes our patients use these same terms to describe themselves. I'm a dope fiend, or I'm a junkie, or I'm an addict. And we use terms like, you suffer from substance use disorder. We try not to say, oh, you're just the tweaker down the hall, which in our emergency department or any emergency department around the country, that phrase is being used today, I promise. And again, back to stigma and how do we talk and the language that we use. If you're looking to afford people an opportunity for care, using language like that creates another barrier. Why would I go see the doctor for my abscess at my injection site? They're just going to treat me like a junkie, right? Again, that's a real consideration and something that we take very seriously in how we address our patients. And part of why I'm giving this lecture is to talk about this, and why I lecture to other healthcare providers is to, again, we have to acknowledge that the stigma is real. We have to acknowledge that if we continue that, then we're only creating more barriers to get the care that we need. So again, that's how we address it. We try and be as compassionate as we can in the language that we use, and we compliment progress, and we champion that change. And whether that change is, I went one day without drinking, well, that is one day that you did. Congratulations. There's a reason that the Alcoholics Anonymous organization gives out a 24-hour coin, and that's because sometimes that's that very first step, and there's any number of ways. The journey of 1,000 miles begins with one step, right? These are the ways that people begin to see the change that will eventually allow them to get the kind of care that they need. So, how do opiates work? And again, I'm not going to spend a ton of time talking about alcohol for this particular lecture, just because most of what we do at Tanana Valley Clinic centers on opiate use disorder. There are other organizations in our community, and I list them all out, that talk about or offer good services and good treatment for alcohol use disorder. Additionally, there's not a lot of regulation from the Drug Enforcement Agency or the FDA on treating alcohol use disorder. There's a tremendous amount of regulation that surrounds how we treat opiate use disorder. And I don't talk a ton about that regulation, but because of that, an organization like Tanana Valley Clinic or other treatment facilities need to be fairly robust in the services we offer, and it's a big deal from a documentation standpoint. But as we talk about, I take OxyContin, for example, or I inject heroin. So opiates bind to the mu receptor. So this receptor exists in many parts of our body, most densely in the central nervous system, the brain and spinal cord, but also it's in your small intestine, it's in your skin, it is all over your body. And when these receptors are bound with an analgesic substance like heroin or like OxyContin, it relieves pain. People feel different, so you get dissociation. So you can actually have almost an out-of-body type perception or experience with it, getting high. People get sedation, so it makes them sleepy. They nod off is a term that a lot of folks will use when they've had too much of an opiate. And what ultimately we care about in the emergency setting or in the overdose setting is respiratory depression. So it actually stops your body's drive to continue to breathe. So ultimately, when someone dies of an opiate overdose, they die of respiratory depression. And this manifests in a number of different ways. But again, particularly, we don't talk a lot about it, but I do have a couple of bullet points on when people mix more than one substance. So if you mix alcohol and opiates, if you mix benzodiazepines, which is another sedating type of medication, with opiates, these are things that generally splash across the headlines with celebrities who've had substance overdoses. Again, when you mix these drugs, that is a recipe for very, very high risk death and overdose death. So additionally, this impacts your GI tract. So people who take opiates oftentimes get constipated because, again, it slows down the transit through your GI tract. So reason I bring this up is there is a phenomenon that is very poorly understood. And what I mean by that is the scientific community understands this very poorly. Me specifically, I promise I've given a lot of thought, a lot of my attention towards how does this happen. But most people who are given opiate pain medicines and take them appropriately, they do experience pain relief. But they also experience these side effects that match up with this, that they don't feel well. They are constipated. They feel out of it. They don't like the way they feel when they take opiates, for most people. But there is a percentage of this population, and I've talked to them about it. The first time they take an opiate, they feel like they can fly. They have all the positive effects, none of the side effects. Is that a genetic predisposition? Is that a product of their experiences when they were small? I don't know. Nobody knows for sure. But those individuals who really like the way they feel when they take opiate pain medicines, they are very high risk for developing a substance use disorder. And again, the number of people in our treatment program who have had that experience is a very common story that I've heard over and over again. And that's very early. Oftentimes by the time they're in our treatment program, they may have been to jail multiple times. Their family doesn't speak to them anymore. They've spent all their money trying to obtain these substances. But for that percentage of people, they get all the positives with none of the negatives. Nobody knows why, but those folks are exceptionally high risk to develop a use disorder on top of their experiences.